We sir and former head of Department of Anesthesia from KMC, Mangalore. He is a person who always supported us in organizing this continuing postgraduate program. And I'm happy to say that he was always present in most of our meetings, and he contributed a lot in all our discussions. We are really happy that he is with us this evening to talk on this very common topic. I'm really honored and happy to welcome Dr. Madhusudan Upadhyaya on behalf of ISA Kerala State Chapter and on my own personal behalf. Welcome you, sir. The second part of the discussion is on anesthetic implication of cardiac reflexes. We have our own Dr. who is the additional professor at Government Medical College, Trichy. As custom demands, I take this opportunity to welcome Dr. Elizabeth Joseph to today's evening meeting of PG Update. We have the President-elect of ISA National, Dr. Giri, with us for a blessing and highlighting the importance of this meeting. Welcome, Dr. Giri. We have the coordinators of today's meeting who are always with us for all the meeting, taking a lot of efforts in organizing it in a great way with a lot of academics and good standards. Dr. Rajesh, who is the Scientific Committee Chairman of ISA Kerala State Chapter, and Dr. Vijesh Venugopal, who is the Governing Council member of ISA Kerala State Chapter at Dr. Rajesh MC and Dr. Vijesh Venugopal to today's meeting. There are many teachers with us this evening. In general, I take this opportunity to welcome you all to this meeting and request you to contribute on this topic of common which appears in the exams. And also, I welcome our vibrant secretary, Dr. Bill Isaac Matthew, to today's meeting. All the teachers, all the delegates, and all our practitioners and officials, I once again welcome you all to this meeting and request Dr. Giri for a few opening words. Over to Giri.
Good evening, President Dr. Nazar, Secretary Binil, today's faculties, Dr. Madhusudan and Dr. Elizabeth, coordinators Dr. Rajesh and Vijesh. Good evening. Continuing with our academic activities, we are moving ahead with this program. Now the World Congress is going on. You must be knowing that though in spite of that, we are having our regular program, keeping in pace that we will have the meetings on all Saturdays. So we are having today. Many may not be attending. I was there. Madhu was very busy with that, and when I called him in the morning, he was preparing for us. I was telling him, what is there? You can tell extempo on diabetes. No, Giri, there are a lot of new things in diabetes, something. It is not that easy. What every day new drugs are coming, new insulin are coming, the pathology changing, physiology changing. We have to know a lot. Not that what we know that. Madhusudan is a good teacher, my mentor, my friend, my teacher, and advisor. And happy that he is there with us today to give. He was there in all our meetings when I conducted in Kasaragod or when we conducted in Kerala. He is there with us, and happy that today he is there. He was busy with his presentations World Congress. In spite of that, he agreed to come and make this. And we have, I see that Dr. Karara, who has just finished that world record making resuscitation efforts, finishing that, because I was also there. Finishing that, he came straight to this our CME. And I especially welcome him for spending this time because he was very busy. And I thank you all for attending and welcome all. And in advance, wish Madhusudan happy birthday and Teachers' Day, which both fall tomorrow. And thank you all for this and have a nice time. Thank you.
Thank you, Dr. Giri. We wish Madhusudan sir a happy birthday. We know it only from Giri right now. And I request the webinar coordinators to take over the proceedings.
Thank you, sir. And good evening, everyone. This, as our president introduced, this is a very common topic, but sometimes very confusing to manage practically, and more so for the postgraduates when it comes to the exam. As far as the 2019 National Diabetes and Diabetic Retinopathy Survey, which report that 11.8% persons over 50 years in India has diabetes. Maybe this is an old statistics, and actually the figures has increased from the previous survey. So definitely every one of us will come in contact with a diabetic patient in our day-to-day anesthesia practice, and there is a lot of things to learn practically on how to manage these patients. And it's a very common topic for the examinations also. That's why we thought we'll get an experienced examiner. And sir has contributed a lot, as our president said. Sir has contributed a lot to the ISA Kerala in the previous PG updates also. And welcome you, sir. Over to you, and happy birthday and Teachers' Day in advance also.
Thank you so much. Thank you. Thanks very much. Shall I start sharing the screen?
Yes, sir, please.
As has already been told in the introduction, diabetes mellitus is a vast subject. I know it is very common. Maybe 1 in 3 of our patients are diabetics, but I'm sure you know more about the disease, you know more about the sugar controls, the morbidity and mortality associated with diabetes will be much, much lower. And as Rajesh just said, India is going to be the diabetic capital of the world. Therefore, as long as you are going to practice in India, you are going to be handling the patients with diabetes mellitus more frequently. At the outset, let me thank ISA Kerala State Branch for inviting me for this weekly program. I think I have congratulated them very often for continuing with this. I think it's an absolutely great achievement when you have gone on week after week, and then PG updates to be thrown in the middle. I think you have been doing a wonderful job. Whether there is COVID or not, I expect you people to continue with this. We should not stop this, because you can reach the unreached much more when you are on a platform like this. I also say hi to the President-elect Venkatgiri. Every time he has been saying those things, I don't know, it embarrasses me a bit. And it's a great feeling that a student who trained with us has reached this level. Hi to Venkatgiri and Nazar, the president, Binil, the secretary, Rajesh and Vijesh, the scientific coordinators, Chakra Rao Garu, and there are so many other seniors and students. As Dr. Nazar said, diabetes, you have to know. As Rajesh said, you have exam questions. Unfortunately, a disease which is as rampant as diabetes mellitus is, you get it as only a short case. Maybe it will be a comorbidity for your IHD or a hypertension long cases, but it's only a short case when it comes to practical exams. But you can get a lot of short notes on diabetes in the theory paper. And also you may get a clinical scenario with the diabetes mellitus as a long case. Therefore, diabetes, as I said, you can't live without diabetes. You have to know in and out of diabetes. If I start talking about every bit of diabetes, I think I need 4 hours. Therefore, decided to, anyway, Rajesh, the topic he gave me was preoperative glycemic control. Therefore, I will stick to that. I'm not going into the pharmacology of insulins, pharmacology of OHAs. I'm not even giving you the classification. And I will just give you an overview of diabetes mellitus and then how the perioperative glycemic control can be done. And I'm open for the questions. Every now and then, if you want to ask me questions, I'm open. You don't have to wait till the end of the program. Okay. Let's move on. Diabetes mellitus. There are a lot of papers available. If you start searching on any of the search engines, you will get a lot of papers. There is one on UpToDate, which is actually very good, perioperative glycemic control. And there are hundreds of them. But I will give you an overview of how to manage the perioperative sugars. I am excluding a few of this. Preoperative evaluation, hospital barriers, common errors in glucose management. We'll talk about the glycemic control and then what could be the recommendations. And I can't jump into the topic. Sorry. I think there's a WCA which went on. Sorry. It was open in another window, I think. Can I just go there and shut that for a while?
Yeah.
Give me a second. Yeah. Okay. As Giri said, actually WCA programs have been very good, and I didn't want to miss much. That's why it was on another window. Yeah, I can't jump into the glycemic control. I will take you through what exactly is diabetes mellitus and how it has become a pandemic along with the other pandemics. It's basically diabetes mellitus is a metabolic disorder which results from insulin deficiency or intolerance, and it's associated with acute and long-term systemic problems. You name it, and the system is involved with long-term sequelae of diabetes mellitus. Whether it is microvascular or macrovascular, diabetes affects it. Every system gets affected, and we are more worried about the CNS, the CVS, and the renal systems. Also, maybe to an extent, we get involved with the peripheral neuropathies or peripheral vascular diseases. But these are basically just to say that it affects every system. The diagnosis, as per the WHO criteria, it is when the sugars are more than 200 milligrams per deciliter, and a fasting glucose of more than 125 milligrams per deciliter. But again, I won't go into the depth of how exactly do you diagnose. Please read for yourself. The two most common forms are still, the classification hasn't changed. They're insulin dependent diabetes mellitus and non-insulin dependent diabetes mellitus. Type 1 and type 2, they are classically known as. I don't know whether it is really the new statistics. Estimated 245 million people are affected with diabetes mellitus globally, and that's about 20% of the adult population, and 5% of all deaths each year. Diabetes is a contributor. Diabetes is the disease which contributes to the death, and 80% of the people with diabetes live in low and middle income countries. That is where we belong to. Therefore, the density of the problem is much more at countries like ours. That's why I said you will encounter diabetes 1 in every 3 patients, especially in a tertiary care hospital or a referral hospital. A few words on type 1 and type 2 diabetes. Type 1 diabetes obviously has absolute insulin deficiency, and there can be autoimmune destruction of beta cells of pancreatic pancreas. And type 1A is autoimmune markers are found in type 1A, and type 1B you don't find an autoimmune marker. Combination of viral infection superimposed on the genetic predisposition is a possibility when you talk about the type 1 diabetes mellitus. Signs of diabetes develop when 80% of the beta cells are destroyed, and the rate of decline is less when type 1 diabetes develops later in life. Therefore, the early onset of diabetes mellitus in younger age, there will be worse decline. And young onset, as I said, is commoner, and it's about 0.4% of the prevalence. And mostly exogenous insulin is required to maintain the plasma sugar levels. You can't manage with any other injectables or oral hypoglycemics. You need insulin. Type 2, that way, is much, much safer than type 1, as you are aware. It's also a combination of genetic susceptibility and environmental factors. We, because of our terrible lifestyle, and maybe our forefathers contribute a bit to it, but type 2 diabetes is rampant. A combination of insulin resistance and relative insulin deficiency, as well as increased hepatic glucose production, are seen commonly, and obesity is associated, as I said. We create the problem for diabetes to affect us. Obesity is associated with insulin resistance. The other one is what you should be aware of is gestational diabetes, and it's any degree of glucose intolerance with onset during pregnancy, and the patients are more prone to develop preeclampsia, and it's a powerful predictor for the development of type 2 diabetes later in life. If the mother during her pregnancy has gestational diabetes, obviously most likely that the patient will have type 2 diabetes later in her life. Complications, I just touched upon them. There is no organ which is not affected by diabetes mellitus. We start with a stroke, heart attack, peripheral artery disease, and diabetic retinopathies, cataracts, glaucoma, diabetic foot, diabetic nephropathy, peripheral neuropathies. As I said, these are the things which affect us: the stroke, the heart attacks, and the diabetic retinopathies, and then diabetic foot. And 90% of the times, be rest assured that diabetic foot is a short case for your exams. And nephropathy is, again, whether it is for transplants or otherwise, you will encounter diabetic nephropathies when you handle your patients. Coming to the topic per se, surgery and diabetes, how surgery affects the diabetes, and how the management of sugars because of diabetes changes, because of surgery changes. Okay. Surgery is very traumatic. What I actually didn't put up was anesthesia too is traumatic. The stress of surgery and anesthesia put together can wreak havoc with the patient when in a diabetic patient who comes for anesthesia. It results in catabolism, increased metabolic rate, increased fat and protein breakdown, and glucose intolerance and starvation. None of this is good for the diabetes and for the problems of the patient. And in a diabetic patient, all the pre-existing metabolic disturbances are exacerbated by surgery and the anesthesia. Please remember that anesthesia is stressful. It's as stressful as the surgery is. What can stress do? It affects the hormonal counter-regulation response. Therefore, it increases the secretions of catecholamines, glucagon, cortisol, and growth hormone, which affects directly the adipose tissues and has effects on the pancreas, and so too on the liver. Adipose tissue, it increases the lipolysis, and there is free fatty acid production, which again goes to the liver, and then finally there is gluconeogenesis, glycogenolysis, and glucose output increases. Effect on the pancreas is reduced insulin production, and then there is hyperglycemia. There will be relative insulin resistance that also leads to hyperglycemia. FFAs inhibit the insulin-stimulated glucose uptake. The lactates and amino acids are broken down in the liver, and the glucose output goes up. leads to hyperglycemia, and the hyperglycemia obviously affects it causes mitochondrial injuries and endothelial dysfunction, immune dysregulation, and superoxide generation. These are the causes for any of the effects, microvascular or macrovascular effects of diabetes mellitus in the human being. This is what I put up on the graph there. And there's much more not much more in this. It's the same thing I repeated. And what the hyperglycemia, how does it hyperglycemia affect when the patient comes for surgery? What is the metabolic response? Glucagon, cortisol, and adrenaline secretion as part of the neuroendocrine response to trauma, combined with iatrogenic insulin deficiency or glucose over administration, may result in hyperglycemia. We said that just now. It causes osmotic diuresis, making volume status difficult to determine and risking profound dehydration and organ hypoperfusion and increasing the risk of UTI. When glucose is an osmotic diuretic, obviously the patient will put out more urine, and unless you replace the volume lost with excess volume fluids, the patient will have dehydration and organ hypoperfusion. That's why any diabetic patient coming to you, controlled or uncontrolled, preferably gets either fluids with sugars or fluids without sugars from the time the patient starts fasting. Osmotic diuresis, delayed wound healing, exacerbation of the brain, spinal cord, and renal damage by ischemia is a possibility because of hyperglycemia. And as I said, it results in hyperosmolality with hyperviscosity, thrombogenesis, and then there also can be cerebral edema. Therefore, hyperglycemia can be life-threatening. So too is hypoglycemia. I need not say that, but hyperglycemia can be life-threatening. Just touch upon the ketosis, diabetic ketoacidosis. Any patient who is in a severe catabolic state and has an insulin deficiency can decompensate into ketoacidosis. It's more common in type 1 diabetes mellitus. There is increased risk post-operatively, often precipitated by the stress response, infection, if the patient has to have myocardial infarction, and failure to continue the insulin therapy due to ignorance of the people involved in management of the diabetes mellitus in the perioperative period. It's characterized again by hyperglycemia, hyperosmolarity, dehydration, and the patient can present with shock and hypotension and excess ketone body production, resulting in an anion gap metabolic acidosis. And the dehydration, the patient would be volume deficient in liters, and ketones per se can be myocardial depressants and vasodilators. Both are deadly combinations, and therefore, once the patient ends up with ketosis, unless you diagnose it early and manage them vigorously, you may not get the patient. Okay, you may not be able to get the patient back. Okay, this is actually the topic is this: the goals of glycemic control. The general goals are maintenance of fluid and electrolyte balance, because we know that the glucose metabolism involves the management of potassium as well as magnesium and phosphates. Therefore, you can't look at only the sugars. You should also look at the other electrolytes. Avoid hypoglycemia. Avoid marked hyperglycemia and prevention of ketosis or hyperosmolar states. If I ask you, hopefully there are postgraduates in this. If I ask you, which one would you dread, hypoglycemia or hyperglycemia? What would be your answer? Hyperglycemia or hypoglycemia?
Hyper.
Hyper. the answer is hypo by quite a few people. Yeah, I think it's acceptable. The hypoglycemia is more deadlier because hyperglycemia, if it has to kill, it has to be a very high blood sugar levels, absolutely high blood sugar levels for the patient to end up with ketosis and then die. Hypoglycemia actually can immediately kill the patient because of lack of substrate for the cellular functioning, and hypoglycemia can kill. So you should be more worried about hypoglycemia, but as I said, marked hyperglycemia is to be avoided. Even that is not going to be safe for your patients. Ketosis, obviously, you have to avoid them. Why am I stuck?
So your sound is very clear.
Yeah, no, the slides are not moving. Moved. Thank you. What are the targets? This is basically, it's $1 million question because none of them has been able to give us the targets as to what should be the range of sugars within which we have to maintain the patient's levels. We still don't have good standardized responses for glycemic targets. Therefore, roughly we talk about 80 to 180 milligrams per deciliter of target glucose range in the perioperative period for a diabetic patient. Basically, that is what American Diabetes Association says, and even Indian Association also has concurred with this. For non-critically ill hospitalized patients, anywhere between 90 to 180 milligrams per deciliters of sugars are okay. There's not much of a difference. Therefore, 80 to 180 is easy to remember, and we will stick to that. But 90 to 180 is 5 to 10 millimoles. Again, that is easier to remember. You can stick to either of this. Okay. Never ever allow the sugars to fall below 100, and we'll talk about that later. Diabetic medications should be adjusted preoperatively to prevent hypoglycemia or excessive hyperglycemia while fasting in preparation for surgery. The problem with most of us, I'm sure the senior consultants also agree with us, most of the electives bar emergency surgeries in diabetics too, we don't get any time to assess the patient and review the patient. You get the patient admitted either in the evening or the next morning for surgery in the morning or surgery in the afternoon. That's all the time you have. And if your internal medicine guy is absolutely good, he knows what he has been doing, maybe you will have somebody whose sugars are under control. Then you also have some surgeons, physicians who just manage the patient's sugars with a lot of insulin intravenous and give it to you saying that the sugars are just where you want them to be, 80 to 180, and what is your problem? Then you have to go and anesthetize because there is nowhere to hide. When the physician says the patient is ready and the surgeon says the physician has given clearance, what is your problem, kind of? That is where we end up with problems. But I think we have to stand up and say diabetes is not as simple a disease as we believe or you make us believe. It is a difficult situation, and you need well-controlled diabetic coming for, unless it's an emergency surgery where you know that risk versus benefit is something which you are going to look at. Otherwise, you have to manage the sugars under acceptable limits for a consistent period of time before you take up the patient, because you don't want the morbidity and mortality to go up just because you didn't have time to manage the sugars preoperatively. And whatever the treatment the patient has been on, you should know very well. Without pharmacology, without physiology and pharmacology, there is no anesthesia. Therefore, you have to know the drugs which are given to your patients, and you should know when to withdraw the patient and when to continue the when to withdraw the drugs and when to continue with the drugs. You have to know. All right. That's why pharmacology should be at your fingertips. And somewhere in the middle, we will discuss about pharmacology. I will only ask questions and I want PGs to unmute and answer. The glycemic control during the perioperative period is difficult to predict because multiple factors affect the blood sugars. It's not just like, even when I'm outside the OR, if I'm not undergoing the surgery, the sugar levels are affected by multiple factors. Maybe the stress levels is one of them, even outside the purview of the OR. And so too, when the patient comes to the OR for a surgery, there are many more issues other than the stress, the acute illness, the anorexia, anesthetic masking of hypoglycemic symptoms, and when the patient is nil per oral. When you say nil per oral, there are very few surgeons who allow the patient to consume clear water, clear fluids till 2 hours prior to anesthetic. The patients fast from we say from midnight 12, but the patient would have a sumptuous dinner at 8 o'clock and then sleep off, and he wouldn't eat or drink till he comes to the OR at 10 o'clock in the morning. That is a possibility. It always happens. And patient sugars go for a 6, go for a toss when you don't see or manage the nil by mouth status. The perioperative diabetic management will need to be adjusted according to the nature of the surgery. When you talk about the nature of the surgery, please remember that only thing you have to look at is when can the patient take the next due dose of insulin or OHS. That will tell you the nature of the surgery, the extent, the length, and the period until overfeeding is restarted. Once the patient can take orally, then most of the problems are solved. Diabetic control comes under your control. Okay. Whether the patient is type 1 or type 2 diabetic, and you should also know about the quality of blood sugar control over a period of time before the patient is coming for anesthesia. And the insulin requirement will drastically come down once the patient begins to recover from surgery. One of the reasons is when the patient is outside the hospital and when he comes to the hospital, his dietary habit changes drastically. He would not eat how much he has been eating when he is in the hospital. It comes down to maybe, according to different people, as per the different people, maybe it comes down by 25 to 50%. That's why the insulin requirement will change when the patient gets admitted to the hospital. As I said, I will go a little unconventionally. We'll talk about each of the drugs and how you manage perioperative glycemia or glycemic control. When the patient is on oral hypoglycemics or non-insulin injectable medications, what will you do? We'll take each category of drugs, SGLT2 inhibitors, and these are the new fad. The examples are given there. They're all tongue twisters, dapagliflozin and canagliflozin and empagliflozin. It should be stopped 3 to 4 days before the surgery. So you have to make it aware to the treating physician that if the patient is on SGLT2 inhibitors, if the patient is scheduled for a surgery, you have to stop it 3 to 4 days. And as I said, you will see the patient at the last moment. Therefore, it is up to the physician to change that, stop the agent. These agents increase the risk of urinary tract infections and hypovolemia. There are also reports of AKIs and euglycemic diabetic ketosis in patients with type 2 diabetes taking SGLT2 inhibitors. Keep all this in mind when you handle a patient with the SGLT2 inhibitors. Every drug, every patient, if he has an altered glucose tolerance, is just not diabetes. Each patient is different. And each patient will come with different drugs, hypoglycemic agents. Therefore, you have to be careful when you handle them. The other oral agents or GLP-1 receptor agonists, if the patients are on this, other than SGLT2 inhibitors, they can be continued until the morning of surgery. And oral hypoglycemics and or non-insulin injectable drugs should be withheld starting on the morning of scheduled surgery. The OHAs and the other non-insulin injectable drugs should not be given on the morning of surgery. I'm not talking about somebody posted for afternoon. This is only if the patient is posted for surgery in the morning. Conventionally, the classical teaching is any diabetic patient has to be the first case on the list. Whether he is an infected patient or otherwise, he has to be the first case on the list. I know that it does not happen routinely, but to reduce the period of time when the patient is not on any sugars, you have to make sure that he's taken up for surgery first and he goes out of the surgery first. Okay. In those situations, the OHAs and non-insulin injectable drugs can be should be withheld on the morning of surgery. If your patient is on metformin, metformin is contraindicated in conditions that increase the risk of renal hypoperfusion, lactate accumulation, and tissue hypoxia. Obviously, the other way, to put it the other way, if the patient is on metformin, you make sure that the kidneys are perfused well and you don't allow the lactate to accumulate. Sulfonylureas and meglitinides, they can cause hypoglycemia. Therefore, you cannot be giving it on the morning of surgery. Even the previous night is a query. TZDs, thiazolidinediones, they may worsen fluid retention and peripheral edema and could precipitate congestive heart failure. Even routinely, even without the stress of the surgery too, the patient can have a lot of fluid retention and they can have CCF. You be aware of it and look for it when you do the PAE. I'm talking about the postgraduates. When your patient is on dipeptidyl peptidase 4, DPP4 inhibitors and GLP-1 receptor agonists, they could alter the gastrointestinal motility and worsen the postoperative state. Since DPP4 inhibitors are generally considered not to increase the risk of hypoglycemia, some experts continue DPP4 inhibitors on the day of surgery. On the day of surgery, I'm a little skeptical, but this is the literature. You can continue on to the morning of surgery if the patient is on DPP4 inhibitors. Move on to insulins. Classification of OHAs and classification of insulins is always a short note question. Maybe the question goes like this, classify insulins, and then they will ask you to write about maybe one type of insulin. I hope everybody knows about how to classify the insulin. You have prandial insulins and you have basal insulin. The prandial insulins, basically the Lispros, Lispro, Aspart, Faster Aspart, and glucine, whatever. And you have regular. And onset of action is about 15 to 30 minutes. Therefore, if you detect hyperglycemia on table, when you occasionally check the sugars, even if you start regular insulin or Lispro, it will take 15 to 30 minutes. And you should know the approximate duration of action, 4 to 6 hours for Lispro and 8 hours for regular. Basal insulin, the types are NPH. What is NPH? What does it stand for? The acronym. Half-life is about 4.4 hours and approximate duration of action is 12 hours. Nobody has put it up at NPH. You have glargines and you have categories of glargines, U100 and U300. And then you have insulin detamers and insulin degludex, that is U100 to 200. That approximate duration of action of all this is quite prolonged. It's about 20 to 24 hours. And sometimes it can be more than 24 hours. Therefore, this is where you have to know what kind of insulin the patient is on. And depending on shorter or longer insulins, you have to withhold the agents. No. What is NPH? Okay, basal, if your patient is on basal insulin only, basal insulin, as I said, it's why am I stuck again? Basal insulin when the patient is only on basal insulin, that is especially when the patient is on once daily basal dosing. As I said, the examples are NPH, Glargine, Detamir, or Degludec. You may continue the basal insulin without any change to their usual regime, as long as the basal insulin dose has been adjusted appropriately. And you have to make sure that the patient does not have anything changed, whether the disease pattern or he has an infection, he has something else, the stress is massively high. And even if you think that over the last 1 month, the sugars have been normal and his HbA1c has been recorded to be normal. If nothing has changed with the person, you may continue with the basal insulin without any change. Often the dose typically is reduced by 10 to 25% on the night prior to the surgery, because there are long-acting insulins. And if you want to give the full dose of insulin the previous night, and when it acts for another 24 hours, which includes the period of starvation for your patient, there is every chance that the patient gets into hypoglycemia. Therefore, the previous night, if the surgery is the next morning, previous night, the dose is reduced by 10 to 25%. You have to make sure it happens. Okay. Any troubleshooting? Can you hear me?
We can hear you.
But why is this? You can see me?
Yes, sir, clear.
But why the slide isn't changing?
Just double tap the Zoom screen, sir. After that, it's moving.
Yes. Good. Thank you. Oh, I didn't know this. If the patient is on twice daily basal insulin, and you may continue the basal insulin without any change in their usual regime, as long as the basal insulin dose has been adjusted appropriately. You don't have to change. As again, the same rider stays, the patient, there should not be any drastic changes in the physiology of the patient. He should not have a severe infection affecting. Okay. You reduce both the doses, the morning and the prior evening, to by about 10 to 25% if there is concern about preoperative hypoglycemia. You will be giving the morning dose of insulin along with the reduced dose the previous evening. It's the same with both single dose, or if the patient is single dose, or twice daily doses. If the patient is on basal and prandial insulin, omit any prandial insulin, regular lispro, aspart, or glulicin after fasting begins, typically on the morning of surgery. The night you would give, but after the dinner or before the dinner, whatever the timing is, but then you don't give the morning dose of insulin, prandial insulin. If basal insulin is given once daily in the morning, advise the patient to give between 1/2 to 2/3 of their usual total morning insulin dose as basal insulin to prevent ketosis during the procedure. It should maintain a steady state of insulin supplies to the patient, even when the patient is going through the surgery. As I said in the beginning, surgery is a stressful situation, surgery as well as anesthetic. Therefore, you need the insulin when the patient is already on a combination of basal and prandial insulin, but don't give the prandial insulin in the morning of surgery, the short-acting one, which is likely to get metabolized within a couple of hours to 4 hours. But the basal insulin, you give 1/2 to 2/3 of the scheduled dose. If the basal insulin is given once daily in the evening, you reduce the dose of the basal insulin on the evening prior to surgery by 10 to 25%. Okay. If it is given only in the morning, you give half or 2/3 of the scheduled dose. If it is given only in the evening, once daily in the evening, you reduce the previous night's dose by 10 to 25%. And then the steady state of sugars and insulin should maintain later. If basal insulin is given 2 or more times per day, reduce the prior evening dose by 10 to 25% unless morning glucose levels are generally high, in which case the full dose can be given. If the sugars are more than 180, that is the target we have. If it's more than 180 in the morning, you can give the full dose and give between 1/3 to 1/2 of the total morning dose, prandial plus basal insulin, as basal insulin in the morning of surgery. If the patient gets more than 2 doses per day, you reduce the evening dose by 10 to 25%. But say today morning's dose has today morning sugar has been exceedingly high, then I give in the night, I give the full dose. The next morning, obviously, I will be giving anywhere between 1/3 to 1/2 of the total morning dose. That is the next morning, right? Today he receives full if the sugars are not under absolute control. Then you also have pre-mixed insulin. When the dose in the evening prior to surgery, it should be reduced by approximately 20%, and the dose in the morning of surgery by about 50%. However, in the morning, if the morning sugar is less than 120 milligrams per deciliter, then you should withhold the drug insulin and you should not give insulin. If only it is more than 120, you give 50% of the patient's scheduled dose. You might get patients who are on continuous insulin infusion, and if they come to you with an insulin pump, then you may continue with their usual basal infusion rate, provided you can retain the catheter and the pump in place during the surgery and in the OR. It should not be disturbed. Okay, and the patient should be awake and alert postoperatively to resume the self-management. If the patient prefers to discontinue the pump at home, say it's a daycare surgery, patient wants to come in the morning and patient has to discontinue, patient doesn't want to take it to the OR, or rather the surgical procedure does not allow that to be carried into the OR, then if the patient has to discontinue the pump at home, and you should administer the basal insulin according to the programmed insulin settings 2 to 3 hours prior to the discontinuation of the pump. Then you discontinue the pump after about, say, a couple of hours. Then the basal insulin levels reach the optimal level and the patient will have proper sugar control. Intraoperatively, how will you manage the glycemia? All this is regarding how do you manage them preoperatively, and once they come to the OR, how will you manage intraoperatively? If your patient is type 2 diabetes treated with diet alone, the blood sugar level should be checked preoperatively and soon after the surgery. And IV solutions do not require dextrose if insulin is not given. Obviously, he's not on insulin, he's on diet control alone. And then obviously you don't have to do anything. You just check the sugars preoperatively and soon after the surgery if it is a minor surgery. For long surgeries, in a diabetic, when you talk about a short surgery, it's less than 2 hours, and long surgery is longer than 2 hours. Surgery or surgeries associated with the expected high blood glucose levels, controlled blood sugar levels, like coronary artery bypass grafting or organ transplants, or with your patients on steroids, or the obstetric patients too included. Intraoperative glucose testing every 1 to 2 hours should be performed. It can be either the laboratory testing, or you can do a point of care testing, like your glucometer reading also will be sufficient. When you need blood sugars to be controlled well, and even it's a long surgery, every 1 to 2 hours you have to check the sugars. And you should supplement the insulin with regular insulin or rapid acting like lisproaspart or glulisin. Insulin may be given as correction insulin. It's subcutaneously in patients whose glucose level rise over the desired target. If it goes beyond 180, you have to give subcutaneous insulin, and it can be a short acting one or a rapid acting one. All right. If your patient is a type 2 diabetes treated with oral hypoglycemic agents or non-insulin injectables, what will you do? Most patients with the good glycemic control, that is HbA1c reading of 7 on oral or non-insulin injectables like GLP-1 receptor agonists, they will not need insulin for short surgical procedures. This is what I said. You should, if the patient can take his next dose of oral hypoglycemics when it is due, then you need not convert to insulins. You need not give insulins for a short surgical procedure. But the blood glucose has to be monitored every 2 hours, again by labs or by glucometry. You have to do it every 2 hours. Okay. For patients who develop hyperglycemia, if the sugars go beyond 180, supplemental short-acting or rapid-acting insulin, as I said earlier, may be administered subcutaneously, typically every 4 to 6 hours, because each of these acts for about 4 to 6 hours, depending on what you have used, based on the measured glucose levels. How much does a unit of insulin bring down blood sugar levels? If it were Sanish, you would have put up a poll. I'm not that smart. How much? You may type in your answers. Correction insulin is administered until the patient is eating and either can resume oral agents or a basal bolus insulin regime. Okay. Most of the diabetic medications can be restarted after surgery when patients resume eating, except for metformin, which should be delayed in patients with suspected renal hypoperfusion until documentation of adequate renal function. If the patient had protracted hypotension intraoperatively during your spinal anesthetic or in your induction of anesthetic, till you have documented evidence that the renal functions are normal, you don't restart metformin. All the other agents can be restarted. Yeah. 50, yes, it's about 30 to 50 milligrams per deciliter is a reduction in the blood sugar levels with each unit of insulin. If your patient is type 1 or insulin treated type 2 diabetic, basically the patient is insulin dependent, what will you do? Generally, the patients who use insulin can continue with subcutaneous insulin perioperatively rather than an insulin infusion for a short procedure. Okay. When it's a short procedure, you can continue with the subcut insulin rather than an infusion. But meanwhile, you start a dextrose containing solution, D5, basically 5% dextrose with either water or 1/2 isotonic saline at a rate of 75 to 125 cc per hour to provide 3.75 to 6.25 grams glucose per hour to avoid metabolic changes of starvation. Insulin is going, therefore, you have to make sure that sugar is also going. And you should remember that 5% dextrose contains 5 grams in a liter. Therefore, when you give 1 liter, the patient gets about 5 grams of sugars, and then insulin, whatever the patient has been used to, will be going subcutaneously. And check the blood sugars either again by lab methods or glucometry. And more frequently, if blood glucose is less than 100 milligrams per deciliter, and or if the rate of fall is rapid, then you have to do it more frequently. You can't allow it. We decided that the sugars we manage between 80 to 180. Therefore, once it reaches 100, the fall will be much more rapid. Therefore, you have to make sure that the blood sugars are checked more frequently and the patient receives more sugars. If the patient develops hyperglycemia, then supplemental short-acting or rapid-acting insulin may be administered subcutaneously based on frequently measured glucose levels. Again, based on how much you want the sugars to come down, you can add that many. There is absolutely no harm in starting an infusion, but there is no need to start an infusion if the blood sugars are just above the range. You can as well manage with a subcutaneous supplemental short-acting or rapid-acting insulin. If the same patient, the insulin-dependent type 2 diabetes or type 1 diabetic patient comes for a long or a complex procedure, IV infusion, insulin infusion is usually required for a long surgery, right? How much will you run? How would you decide what should be the dose of insulin infusion? Generally, you can type down your answers. Generally, insulin infusion should be started early in the morning prior to surgery to allow time to achieve the stable glycemic control. You do the sugars and then you start the insulin infusion. But when the infusion is going, there has to be close monitoring of the sugars and insulin infusion protocols whenever possible. There are quite a few protocols available. I'm not going to talk about them, but if you need me to answer your queries, I will, if the time permits, later. There are quite a few. What is my favorite is actually the classic non-tight control regime or the tight control regime, as Miller says. It's a fabulous one. Somehow I love that, the tight control or the non-tight control regime. And electrolyte monitoring, I told you some time back that potassium, phosphates, and magnesium is something which you have to keep an eye on, and the bicarbonate levels too. If the patient is insulin dependent type 2 or type 1 diabetes, short procedures you can manage with subcutaneous insulins, but long and complex procedures you go for IV infusion. Nobody has put up the answers. Yeah, Gurda said yes. Sorry, 5 grams in 100 ml. You're right. I was wrong there. Yeah. An important note is that insulin infusion should not be stopped altogether. Even if hypoglycemia is present, you will basically balance the insulin infusion versus the sugars without basal insulin for patients with type 1 diabetes to prevent ketosis. In cases of hypoglycemia, insulin infusions may be reduced and the glucose infusion increased to maintain glucose targets. Therefore, it is preferable that you have 2 different IV lines to run the sugars and to run the insulin. Okay. And with this regime, dextrose is administered at approximately 5 to 10 grams of glucose per hour, and a separate insulin infusion is given. So what I said just now, using short-acting insulin. And many type 1 diabetic patients require an infusion at a rate of 1 to 2 units per hour, while more insulin-resistant type 2 diabetes patients may require higher insulin rates. Yeah, nobody typed in how much to give. You can always divide it by, when you talk about tight control regime is practiced for neurosurgical procedures or CABGs or obstetric patients or somebody who is on steroids. you divide the sugars, the calculated sugars, divided, or rather blood sugar levels divided by 100, and the rest of the patients you divide the sugars by 150 and round it off to the nearest whole number and the insulin. Okay.
So, slides are not moving. I think it is stuck.
No, it's not. I just, I'm sorry. My son is driving down from Mysore and he called. That's why I thought I would take the call. I could not.
Oh, it's okay, sir.
Yeah, as I said, you have to have two different lines for insulin and glucose, and then you may, I just gave you the formulation, how much to use. Yeah. And yeah, this is what I just said. A rate of insulin infusion should be titrated depending on the procedure and degree of insulin resistance. In a nutshell, just to make it very simple, for minor and intermediate surgeries in a diabetic patient, if the patient is on diet control, you treat it as normal patients and you don't need to do anything about it. And you don't have to look at insulins. If the patient has been on oral hypoglycemic agents, you skip the morning dose, return to oral hypoglycemics, and diet in the postoperative period as soon as possible. You monitor the blood glucose 1 hour pre-op and once intraoperatively, and 2 hourly till eating, then every 8 hourly. If the patient is insulin dependent and is for minor or intermediate surgeries, no insulin, no glucose. Don't have to start insulin. You don't have to give insulin, glucose either. Restart with the first meal. The insulin will start with the first meal. But you monitor the blood glucose just like the other group, OHS, 1 hour pre-op and once intraoperatively, because it's a surgery which lasts only 2 hours. Therefore, once is more than enough. And 2 hourly till eating, and then 4th hourly, because you have restarted insulin once the patient starts eating. As I said, the patients, why you should be watching every 4th hourly is these patients will not eat as much as they would eat outside the hospital. Therefore, you have to be a little skeptical, and the incidence of hypoglycemia is more. When the patient comes for major surgeries, in a patient who is diet control, has diet control diabetes, monitor the sugars and start insulin as needed. We have discussed. We will just, depending on what kind of insulin the patient is on, start the insulin as needed. On OHS, if the patient is on OHS for major, you convert to insulin preoperatively and make sure that the patient's sugar levels are stabilized. It's not enough if the patient is put on the insulin the previous evening and then the next morning you take up for surgery. No, make sure that the patient is stabilized before you take up. Okay. And if your patient is insulin dependent, perioperative insulin as per the tight control or non-tight control regime. As I said, I love this regime. Maybe that is why insulin dependent patients, depending on the situation of the patient, what the surgery is he for, you can go for tight control or non-tight control regimes. When you are talking about tight control regime, obviously the sugars, the target sugars would be anywhere between 79 to 120. And when it is non-tight control, we are not so rigid, and therefore you can have the sugars a little away from the target of 79 to 120. It can be 80 to 180. This is what I said. There is a classic non-tight control, tight control regime. There is Hirsch regime. There is Alberti's regime, which is glucose, insulin, and potassium, and then modified sliding scale. Somehow I am not very convinced about the sliding scales, and so too the modified sliding scale. But Alberti regime is a sensible one. Hirsch is all right. Non-tight control or tight control regime is something which I would love to go with. Postoperative glycemic management is generally it is continuation of what you have done intraoperatively. If an insulin infusion has been used, it should be continued postoperatively in patients who do not resume eating. If it is a major surgery, a gut surgery, obviously the patient will be starved and continues fasting, and therefore you continue with the insulin infusion. You continue to monitor the plasma glucose every 1 to 2 hours when the patient is on insulin infusion. And once it seems likely that the solid food will be tolerated, the patient can be transitioned to a subcutaneous regime, and then the insulin infusion can be discontinued. You have to make sure that the patient has converted his dietary habits to his almost regular eating habits. Because the short half-life of IV regular insulin, the first dose of subcutaneous insulin must be given before the discontinuation of the IV insulin. We should know the peak action of the drug which you inject, subcutaneous insulin, to match with that. Then you can reduce or cut off the intravenous insulin infusions. If intermediate or long-acting insulin is used, it should be given 2 to 3 hours prior to discontinuation, whereas short or rapid-acting insulin should be given 1 to 2 hours prior to stopping the infusion. If the patients are treated with subcutaneous insulin, if he has not resumed eating, continue with the subcut insulin along with IV dextrose. Okay, the sugars have to go in at a rate of 100 mils per hour of 5% dextrose in water or 1/2 isotonic saline to prevent hypoglycemia and reduce stress-related proteolysis and catabolic changes. You can't afford to have hypoglycemia, you can't have catabolism. Once the patient can tolerate the food, their subcutaneous basal bolus insulin regime can be restarted. For patients with type 2 diabetes who are hospitalized after their procedure, oral intake is almost, that's what I said in the beginning. Therefore, you have to reconsider how much he has been eating earlier and now. Therefore, you need a dietitian to look into this. All by yourself, it may not be able to see how much he eats and how many calories are going in. In type 2 diabetes, insulin requirements are sensitive to reduced intake, and therefore it may be necessary to reduce the typical outpatient dose of basal insulin, often by about 25% to prevent hypoglycemia. When to resume the oral agents? Sulfonylureas stimulate the insulin secretion, therefore the patient might have hypoglycemia if you give sulfonylureas and then the patient is not eating well. Therefore, you have to start sulfonylureas only after the eating has been well established. A step-up approach can be used for patients with high-dose sulfonylureas, starting at low doses and adjusting them until the usual dose is reached. Metformin should not be restarted in patients with renal insufficiency, significant hepatic impairment, or congestive heart failure. I told you earlier. The GLP-1 receptor agonists should not be restarted until post-anesthesia nausea or vomiting, if present, has resolved and the patient is eating normally. And TZDs, thiazolidinediones, should not be used if patient develops congestive heart failure or problematic fluid retention. We have discussed this already. If there are any liver function abnormalities too, because they can alter. DPP4 agents may be restarted in the postoperative period when the patient is eating, as the risk of hypoglycemia is low. And coming to the SGLT2 inhibitors, it should not be restarted in the inpatient setting due to risk of dehydration, volume contraction, genitourinary tract infections, and DKAs. For patients having day surgeries, they can be restarted when the patient is eating and drinking normally. Last few minutes, maybe I will wind up in about 5 minutes time. We'll talk about a few of the special considerations. One of them is glucocorticoid therapy when the patient is on glucocorticoids. It can worsen the pre-existing. Obviously, we know that sugars can go awry with glucocorticoids, and it may precipitate steroid-induced hyperglycemia even when the patient does not have a pre-existing diabetes mellitus. Any of the oral hypoglycemic medications can be used, and looking at the patient profile, what suits the patient the best, with a constant dose of steroids and minimal elevation of blood sugars. When it's only about less than 200 milligrams per deciliter, you can manage with oral hypoglycemics. And oral hypoglycemics, as I said, depending on the patient profile, you can decide. When the sugars are more than 200 milligrams per deciliter, you need insulin to be started. And for patients who are started on large doses of steroids or who have their dose increased significantly, a 2 to 3-fold increase in the total daily insulin dose is frequently needed in patients on high dose steroid therapy. If the patient is on pulse therapy, if he's on massive doses of steroids, you have to increase the insulin. Obviously, you can't worry about the numbers. You have to make sure that the sugars are kept under control. And for such patients, a variable rate insulin and glucose infusion may be appropriate, especially with a variable dosing of glucocorticoids. Even otherwise, you need to keep a constant watch on the sugar levels, irrespective of the steroids. The other special situation is hyperalimentation. When you put the patient on TPN or total parenteral or enteral nutrition, that has a lot of sugars. Therefore, blood sugar levels will climb up hugely, and maybe you need large doses of insulin to maintain the glycemic controls, especially in diabetic patients. And if you are doing nasogastric feeds, and if you have any breaks in the feeding in TPN or the nasogastric feeds, you have to watch the sugars. There is every likelihood that the patient who is on insulin along with the alimentation, hyperalimentation, they can end up with hypoglycemia. Therefore, you have to make sure that the patient receives IV dextrose. You have to have good communication between the surgeon, dietitian, and the person managing the diabetic care, the physicians, right? I think I have spoken at length about all this. I don't think I have to go through this again. And little more about the advances in technology. There is continuous glucose monitoring of interstitial glucose, CGM, and automated insulin delivery devices. And results suggest improvements in diabetes control with CGM, with greatest benefits seen with near continuous use. But can the patient carry this into the OR? And during ambulant and short stay surgery, it may be appropriate to continue the use of advanced insulin pumps, in which the anesthesiologist and the institution is able and prepared to take temporary responsibility for managing the device. Since it's an expensive device and the patient controls it, it might not be very easy for you to take over, and somebody has to be responsible for the equipment when it comes to the OR. The device, otherwise, the device can be removed and insulin, you can start an insulin infusion, and if you are more comfortable with that, you may continue the CGM and insulin pump for minor procedures, but some manufacturers advise that insulin pumps and CGM sensors and transmitters should not be used in association with MRI, computed tomography scanners and fluoroscopy and when diathermy is being used. It's unsafe and it may not deliver what it is set out to deliver. Therefore, maybe you have to disconnect and then look at insulin infusions, or you have to look at managing otherwise. Only one slide on DKA because the PG update the other day, I had discussed a case on diabetes, and we discussed at length, me and Malli discussed at length about ketoacidosis. I think you can go to YouTube and pick it up. Few of the things which you have to look at when the patient comes for an emergency surgery with diabetic ketoacidosis is make sure that you have started an insulin regime. There are lots of them, and 0.1 international units of insulin per kg to be given, and then as a bolus, and then you give it as an infusion. You can do whatever you are comfortable with and whatever your institution recommends. At least make sure that there is partial correction of hypovolemia. You may not be able to do every bit of justice. You may not be able to pump in all the liters of fluids the patient has been deficient in. But you have to manage hypokalemia and acidosis. Otherwise, they can alone kill your patients, and make sure that the patient is not absolutely dehydrated and starts putting out urine. These are the three things which you have to keep in mind when you take up with an increased risk, obviously, when the patient comes for emergency surgery, when the patient has DKA. We're not going to discuss that in this. Okay, last couple of slides. The bottom line, it sounds very simple, and if you apply yourself, if you get involved with the management of the patient, not just a few hours prior to the scheduled surgery, then you can manage the sugars. And if you are not at all happy with the sugar control, HbA1c of 11 and sugars of 300, you need not be bogged down to take up the case, and you can always ask for optimization, and you can also be a part of optimization. All right, on an hourly basis or a couple of hours, you should be able to dictate what you want. Ask key questions, and most of it is about the end organ damage, microvascular or macrovascular damage the diabetes can cause, and then how much your airway management or gut motility affects your anesthetic, or would you like to have the patient awake during surgery? Ask yourself key questions and get answers, and then go ahead. To decrease the complications, obviously, primary nausea. Monitor the sugars very frequently, 1 to 2 hours, depending on what kind of drugs you have put the patient on. If the patient is on insulin infusion, every hourly, otherwise every second hourly. Low threshold insulin is, you should not be worked up too much to start the patient on insulin, because adequate control over the sugar levels is what we are looking at, and avoid hypoglycemia. As I said, if your patient does not wake up, hypoglycemia is one of the reasons which would have made sure your patient does not come around. Therefore, you cannot allow the patient to go to hypoglycemia. That becomes an iatrogenic mistake. Avoid sliding scales, which is, we all believe that they're the most unscientific ones. And diabetes education and long-term management of the patient, you can always get involved with. To conclude, the diabetic patient presents numerous challenges to manage during surgery. Awareness of the complications should enable tight metabolic control, and correct management reduces morbidity and length of admission, as well as resulting in better wound healing. As I said, there are a lot of articles available. Please read them. And whenever this is available on YouTube, you people can watch them at a later date. Thank you very much. I know I have overshot time by many minutes. I'm sorry about it. And thank you so much.
Thank you, sir. The time is not a limiting factor. This is an important lecture. I think it's going to be a reference lecture in the YouTube for the postgraduates to refer before going for their practical as well as theory exams. I think there will be a lot of questions. Queries, we'll go to the chat box and comments from the senior faculties. And before going there, before taking up the questions, can I ask you, sir, one question?
Yeah, sure.
Yeah, what is the protocol in the face of ERAS protocol? Like, do you preload the patients? Because ERAS protocol means we actively encourage the patients to take oral complex carbohydrate drinks 2 hours before surgery. That's carbo load.
Yeah.
So what is the protocol in a diabetic patient?
If the patient is absolutely under control, diabetes is under control, we would not, we would not hesitate to load them with the carbohydrates.
Okay.
If the patient is not under good control, not controlled diabetes, then obviously we have to restrict the sugars. We will only give maybe sugar-free fluids, depending on what the sugars the patient presents with.
Okay.
And if the patient has an uncontrolled diabetes, obviously the patient doesn't deserve to be under the ERAS protocols. Therefore, we don't look at the enhanced recoveries.
Okay, sir. So I am usually hesitant to prescribe carbo load in diabetic patients.
Yeah, diabetic patients, you have to watch the sugars when the sugars get absorbed, and your insulin management begins then. If the patient is on OHS, I think it's safer to avoid the glucose-containing glucose-containing fluids.
Okay, sir. Thank you. So can we go to the questions in the chat box?
Yeah, there is one question on your experience with COVID patients in managing raised sugars. It's a very good question. Now I have to think. I think we have done the same way, because our mucor cases or tracheostomies or cesarean sections, cesareans, whichever I didn't have diabetes mellitus or gestational diabetes. Mucors, lot of them had diabetes. We followed the same principles, whatever I spoke till now. And I am a great fan of, as I said during the lecture, I'm a great fan of non-tight control and tight control regimes. And I try to follow that most of the times.
Do you personally use JIC or Alberti regime or insulin and glucose in separate infusions? What is your preference, personal preference?
No, I said depending on what the patient has, tight or non-tight controls. Alberti's regime, we don't. GIK, in our place, the physicians seem to love, and I somehow don't like so much. And tight control regime is something which I follow for the patients who need them, and otherwise non-tight control. Anybody use Alberti's regime intraoperatively, the GIK? Dr. Meenakshi?
So you use insulin and glucose separately?
Dr. Madhusudan.
Yep.
I think I'm pronouncing your name rightly.
No.
I have sent a message to Madhusudan. During the Krishna Jayanti time, Madhusudan is necessary, compulsory. But as you said, people are following various techniques. I am reading everything and I am following ALM's technique. That is AL Meenakshi technique.
Yeah, I understand. Yes, what is that?
Anyway, as you said, non-tight control is better. Instead of saying it is a loose regimen, loose means it will connote as a lunatic. So we are saying it is non-tight. It is loose only. Always loose is preferable. Thanks then. I'm here only for your lecture. It is excellent, marvelous. You have covered everything till the newer version. It is good. Thanks. Then.
Thank you. Thank you, boss. Thank you.
any comments on this in lectures? Dr. Mubarak and Dr. Shamshad.
Venkatagiri.
Of course, Giri is there.
Mubarak is there.
No, I thought he was there, but I didn't see him in the.
Yeah.
Hello, Matsudan.
Yep.
Hello, Matsudan.
Guru,
Yes,
sir.
Dr. Gurudat.
Guru, heli.
Yeah, fantastic lecture, man. It's a highly informative lecture, and as Rajesh was talking about that, this can be a reference lecture for most of the postgraduates in the coming days. Very, very informative. Really, very thankful to you for a fantastic lecture.
Gurudat
One
has
thing
been
I
my, yeah. One sec. Gurudat has been my co-postgraduate, but when it comes from Gurudat, I think it is. Thank you so much. Yeah, tell me.
No, one thing I just want to add now, do we still practice this tight control regime? Because, many of the studies have found out that tight control regime is more dangerous. And as long as you keep the blood sugar, even for major surgeries lasting for more number of hours, even for cardiovascular surgeries, neurosurgeries and all, as long as you keep the blood sugar between 120 to 150, it is fine. And for all other surgeries, as long as the blood sugar is between 120 to 180, it is fine. Even in patients who are critically ill in ICUs and even pregnant patients and all patients, ideally, many of the papers have found, studies have found out that tight control regime may not be an ideal choice because still hypoglycemia is a killer. Hyperglycemia may not produce so much of problem as long as permissive hyperglycemia is there up to 180. 180 is permissive hyperglycemia. And for major surgeries, 150. That's what is ideal. Probably I also feel like that. And the other thing I just want to add is, now so many oral drugs have been introduced and many of the postgraduates will have a lot of confusion regarding these. And you have excellently discussed about all these oral newer agents and what to do and when to stop and when not to stop and to continue all those things. That's very nicely, discussed. The other thing is, nowadays, subcutaneous insulin, we never used to use during intraoperative period. Now it has been introduced, subcutaneous, especially the ultra short acting subcutaneous insulins like Lispro or Aspart and all. So for that, they say that you have to calculate the insulin sensitivity factor. So if the patient is on insulin, subcutaneous insulin previously, you just divide 1,800 by the total number of insulin units the patient is taking, and that you can derive the insulin sensitivity factor. So based on that, intraoperatively, you just see what is the blood sugar divided by the sensitivity factor. So many number of units of ultra short acting insulin, that is insulin analog, subcutaneously give. So this can be done every hourly. And this is what one of the things, because I joined late to your lecture, about almost 20 minutes late. I don't know whether you had discussed about insulin sensitivity factor or not.
No, I avoided all that because as such it was going to be so long. That's why I kept them out.
Dr. Madhusudan,
Yep.
I have a doubt.
Yes.
Usually in any batch of postgraduates, only one will be extraordinary and only one will be handsome. But how come in your batch 2 are extraordinary and 2 are handsome? With Gurudat and yourself.
Gurudat is head and shoulders above me, man. Don't compare Gurudat to me.
It is unbelievable. How come 2 can be extraordinary and 2 are handsome?
I told you, don't compare me with Gurudat.
So Dr. Meenakshi has to comment like this in every
I think after the hardcore subject, we need something like, hey, Malli, hi, unmute mada.
When I saw you and Gurudat discussing, I thought I should show my face.
Yes,
I also was along with you fellows.
Yes. Now,
And
Meenakshi, you have a doubt about...
One thing about diabetes is these days we get a lot of patients with diabetes. Unlike an institution in private setup, morning the patient gets admitted with 350 blood sugar. and evening the case is posted for surgery. Right, Madhu?
I just said that actually.
And I have been doing these cases. For the sake of postgraduates, always when I am told that the patient's blood sugar is 350, I just ask them, give them a start dose of insulin IV, that is 0.1 unit per kg body weight, then probably start them on some IV fluids, normal saline, monitor the blood sugar every 4th hour, and by evening the blood sugar is around 150, 160, start them with dextrose and insulin, and take up the case for surgery. Just yesterday, I had one patient, 92-year-old lady, for radical mastectomy, hypertensive diabetic, with her blood sugar at 350 at around 2 in the afternoon. Case was posted at 6 in the evening. With one shot of 6 units, the sugar dropped down to 56. Then again, I had to put her on dextrose. We finally ended up finishing the case and the patient is doing fine. So diabetes is one thing that every second patient is a diabetic today when I'm managing these patients.
Agreeable. Yes.
And one more thing, Madhusudan, that most of the institutions are still following no insulin, no dextrose intraoperative.
Yeah.
Safest probably the regime.
Safest, yeah. It's safest. No, if the sugars are under control, yes, it is quite safe.
Yeah.
It's quite safe.
No, if the sugar comes down to less than 250, you still want to use only no insulin, no this one, or better to go for dextrose with insulin, so that you are giving some substrate also in a diabetic patient, which is again important, instead of just giving normal saline.
Dr. Madhusudan, the carry home message you have given is excellent. It is clear cut. It depends upon the duration of the surgery, whether it is no insulin or no glucose, everything depends upon the duration of the surgery. If it is within 2 hours, nothing is going to change. And whatever we read, whatever regimen we follow, again and again, it is testing glucose and using insulin or sugar. This is the crisp. Whatever you read, you have to again and again test. It is only a clinical parameter. Test, give insulin or sugar.
And as Dr. Meenakshi was talking about, what is most important is perioperative monitoring of blood glucose.
Yes.
That is the most important thing. Avoid hypoglycemia for any this thing. So maintain blood sugars up to 180, fine. Fantastic.
Sir, that is a good concept. So as a corollary, I want to inform the postgraduates, hyperglycemia is preferable than hypoglycemia. Hypertension is preferable than hypotension. Hyperoxia is preferable than hypoxia. Hypercapnia is preferable than hypocapnia. Thank you.
That's a good take-home message. We are always worried about hypoglycemia in the intraoperative settings than a mild hyperglycemia.
That was like Meenakshi's poetry.
Yeah, we tend to err on the side of hyperglycemia always. Yeah. So, any more questions in the chat box?
I have one doubt.
Umesh says there are questions on the YouTube. I don't know how to reach.
Madhusudan.
Yep.
Dr. Binil, can you help me to sort out the questions in the chat box?
I'll just post the YouTube questions.
Is there any point in correcting a glucose within 2 hours and taking surgery, or it's okay? It is not going to make much change. That's what one physician said, that 200-300 sugar, that I will manage it afterwards. Why you want to bring down? And his body was adjusted to 300 sugar. Why you want to worry?
No, Venkatgiri, can I answer you, Venkatgiri?
Yeah, hello.
More than the sugar, it is the volume what we have to correct. Along with the volume, it is the acidosis which we have to correct. Whenever the patient is having higher blood sugars, we should always think that there is some diabetic ketoacidosis. One. And when a patient is in diabetic ketoacidosis, there is always associated volume depletion. And when you anesthetize these patients, even if you are not trying to get down the sugar, the volume correction has to be made, which will take care of the acidosis and probably will be able to manage the patient. But since the sugars are so high, along with the volume, we would like to bring it down to 150, 160 before we take up for surgery. Volume correction and correction of acidosis. Am I right, Madhusudan?
No, thing is, no, his question was something else.
Yeah, high
He
sugars.
wanted to know whether you can This is, that's what I said sometime in the beginning. We have some people called the surgeons, physicians, that become an accepted terminology now. These are the people who clear the patient for surgery and anesthesia within the shortest period of time. They would give IV, they would surely give IV insulin and then get the patient ready for your surgery or anesthesia. But I'm very skeptical about these things, because if you drastically bring down the sugars, obviously the patient can move towards hypoglycemia very fast. And are we checking the sugars that frequently? And if you give IV insulin every hour, you have to, or even shorter time, you have to check the sugars. Forget about the labs. You can do the glucometry. You have to do it. Otherwise, it becomes. Yeah. Now there is a question.
Make sure that you have corrected the volume also.
Yeah, exactly. That is only when there is a DKA, when there is hyperglycemia and the patient has been having osmotic diuresis, then you have to look at the volume. Otherwise, when there is hyperglycemia alone, unless there is, it's not that we haven't done. There is a question in the chat box if FBS and PPBS are acceptable. HbA1c is above 8. Again, it tells you that long-term management of the diabetes has been haywire, and the outcome may not be very effective. There is increased morbidity, and mortality is also a possibility. That is when we have to be skeptical, and you can look for more optimization of the sugars. But I don't think any of your surgeons would like to wait. Even if it is an absolute elective surgery, they would not wait. When the FBS and PPBS are normal, they would say, why don't you take up? But take increased risk consent. Postoperative morbidity is higher in these patients. And watch the sugars intraoperatively. You are safe.
There's another question. There is advantages of human insulin
Oh,
versus
that I said, the pharmacology I'm not going to talk about. They can read.
Okay. So can we, if there is...
Sir, I got one announcement.
Yeah.
So next week we are planning for 2 lectures on next Saturday, of course, at 6 p.m. The first topic is respiratory mechanics by Dr. Sachin, HOD of Department of Anesthesia, Rajagiri Hospital, Cochin. And the second topic is coronary circulation for anesthesiologists by Dr. Ranjit Karthikeyan, Professor and HOD, SRMC Medical College, Chennai. So I request all the PG students and our colleagues to join us at 6 p.m. Next week, next Saturday. So over to Rajesh, sir, please.
Thank you, Dr. Binil. If there is just one more question, Madhusudan sir, when should we start insulin intraoperatively in a patient who is on OH?
It's not intraoperatively, it is preoperative. You have to convert from OHA to insulin when the patient comes for a major surgery. As I said, in diabetics, the very definition of minor surgery is when the patient can take the next dose of oral hypoglycemic scheduled. Say it is once a day, twice a day, or 3 times a day dosing. If the patient can take the next dose due early, then it's a minor surgery. Then you don't have to convert into insulins. If it is a major surgery, you have to convert to insulin and stabilize the patient. That's also I said. You have to stabilize the patient. Just because you have given 1 shot of insulin, you can't take up for surgery or anesthesia. Stabilize the patient for more than a couple of days, and then only you take up for anesthesia.
There is one more question in the chat box by Dr. Sunjit Ravi. Can you see that? Is there any
neutralizing equivalent dose for steroids and insulin? There's nothing like that. But when you talk about tight control regime, obviously you divide the sugars by 100 and give the insulin when the patient is on steroids.
Okay, sir. Thank you for the excellent lecture. Can we go to the next session? If I don't think there is no more questions.
Thank you so much, ISA Kerala. everyone associated.
Thank you, sir.
Thank you.
So we'll go to the next lecture. We have Dr. Elizabeth Joseph, who is a professor of anesthesia at Government Medical College, Thrissur. She'll be speaking on anesthetic implications of cardiac reflexes. Over to you, Dr. Elizabeth, madam. Madam,
please unmute and please start. Madam, please unmute. Madam, please unmute. Madam, you are not audible. Please unmute.
Sorry for that. Can you hear me now?
Yeah, it's audible, madam. Thank you.
Yeah, okay. Sorry for that. Okay, thank you very much, ISA, for giving me this topic. After this very interesting session by Madhu sir, we'll go to a totally different topic. I will be talking about cardiac reflexes and the anesthetic implications of cardiac reflexes. So right from the days we joined for our post-graduation, we hear about Bainbridge reflex, Basol-Jari reflex, Jarisch reflex, the baroreceptor reflexes, all the different reflexes which are very much part of our day-to-day anesthetic management. And let's just have a quick overview of how, what are the implications for these various reflexes in our anesthetic management. So basically, cardiovascular reflexes are fast-acting reflex loops between the heart and the central nervous system. And they contribute to the regulation of cardiac function and maintenance of physiological homeostasis. So ultimately what they do is they regulate and modulate cardiac function and vascular tone. These reflexes, there are receptors from where the reflexes originate. So they may be either cardiac reflexes or extracardiac. The cardiac reflexes are found in the atria, the ventricle, pericardium, and coronary arteries, whereas the extracardiac receptors are there in the great vessels and the carotid artery. And from these receptors, the stimuli are linked to the CNS by either myelinated or unmyelinated afferent fibers. And once they reach the CNS, the sympathetic as well as the parasympathetic nerve input is processed within the central nervous system. And once this is processed, after the central processing takes place, the efferent fibers take the responses to the heart or the systemic circulation, depending on what the specific reaction is. That depends on what the stimulus was. So you have an afferent limb, that is a sensory limb, that is from the receptors. This afferent limb goes to the central nervous system. It is integrated in the central nervous system. And from there, you have an efferent limb. So this is the basis behind these cardiovascular reflexes. So these are the various cardiovascular reflexes which I will be briefly discussing: the baroreceptor reflex, the chemoreceptor reflex, the Bainbridge reflex, Basol-Jarisch reflex, Valsalva maneuver, Cushing reflex, and the ocular cardiac reflex. So coming to the baroreceptor reflex, which is the commonest reflex that we all talk about and which we all know, this is a reflex which regulates arterial blood pressure. So this is one of the most important reflexes because it regulates arterial pressure around a preset value. So there is a preset value and the arterial pressure is regulated around this particular value through a negative feedback loop. So there are baroreceptors found in the carotid sinus. You can see from the picture on the left, the receptors in the carotid sinus, which is at the bifurcation of the external and the internal carotids, and in the aortic arch. So from the carotid sinus, this is carried through the sinus nerve, that is the nerve of Herring, which combines with the vagus, and it goes to the nucleus tractus solitarius, which is located at the cardiovascular center of the medulla, which receives the impulses from these stretch receptors through afferents of the glossopharyngeal and vagus nerve, as I told you earlier. So the cardiovascular center in the medulla has got two functionally different areas. One is a center which is mainly involved in increasing the blood pressure, and this center is laterally and rostrally located, whereas the other center for lowering blood pressure is centrally and caudally located. So this is what happens when there is an increase in blood pressure. You have the baroreceptors in the carotid receptors and the aortic receptors. There is a firing of baroreceptors in the carotid arteries and the aorta. And through the sensory neurons, the stimulus is passed on to the cardiovascular control center in the medulla. And so what happens is you have a decreased sympathetic output and an increased parasympathetic output. So this is all that you need to remember, because once you remember this, then the rest of it falls into place. There is a decreased sympathetic output and there is an increased parasympathetic output. So because of the decreased sympathetic output, you have vasodilatation, decreased force of contraction, and a decreased heart rate, which all leads to a decrease in the blood pressure. And because of the increased parasympathetic output, you have an decrease in heart rate. So ultimately what happens is there is an increase in blood pressure because of these receptors are stimulated. The sensations go to the medulla, and from there, as a reflex, there is a decreased sympathetic output, increased parasympathetic output, and the blood pressure is lower. And then there is a negative feedback loop where once this blood pressure is decreased, there is a negative feedback onto the baroreceptors so that the output is stopped. So basically this cycle is what maintains the blood pressure in a preset value. So what are the anesthetic implications for this baroreceptor reflex? The stretch receptors are activated if the systemic blood pressure goes above 170 millimeters of mercury. And when the blood pressure is below 50 millimeters of mercury, the reflex arch loses its functional capacity. And this responds more to a rapidly changing blood pressure rather than a stationary blood pressure. So if you're a chronically hypertensive person, the preset value gets reset. So it responds more to rapidly changing pressures. While we're giving anesthesia, what is important is that volatile anesthetics, especially halothane, which we hardly ever use these days, inhibits the heart rate component of this reflex. So there is as I told you earlier, there is a heart rate component, and this heart rate component of this reflex is inhibited by volatile anesthetics. Additionally, there are some drugs like calcium channel blockers, ACE inhibitors, phosphodiesterase inhibitors, which all can alter the reflex. So the cardiovascular response of raising blood sugar through the baroreceptor reflex is decreased by when patients are on these drugs. And also on patients who are chronically hypertensive, their baroreceptor reflex is also decreased. So they often exhibit a perioperative circulatory instability. So these are the things that we need to remember while anesthetizing patients who are on these drugs or patients who are chronically hypertensive. Then the other thing is we all talk about carotid sinus massage when we talk about management of supraventricular tachycardia. So the principle behind that is when you rub the neck over the carotid sinus, there is a mechanical stimulation of the receptors. So this mechanical stimulation of the receptors increases their firing, and this leads on to a decreased sympathetic as well as an increased parasympathetic outflow from the medulla. And this is used to abort certain types of arrhythmias by activating the vagal efferents. So this is the principle behind using the carotid sinus massage. Next is the chemoreceptor reflex. which is again located in the carotid bodies and the aortic body. This reflex is a response to changes in the pH and the blood oxygen tension and the carbon dioxide levels. So a fall in the PaO2 below 50 millimeters of mercury, or acidosis, or a rising carbon dioxide level will all cause a change in the will stimulate these receptors. So the impulses are taken along the sinus nerve of Herring, which is a branch of the glossopharyngeal nerve, and the 10th cranial nerve to the chemosensitive area of the medulla. And once it goes there, this responds by stimulating the respiratory centers and increasing the ventilatory drive. And again, in addition to stimulation of the respiratory centers, you have activation of the parasympathetic system, resulting in a reduction in heart rate and myocardial contractility. If there is a persistent hypoxia, so this is a response to an immediate drop in PaO2 or acidosis or a rise in PaCO2. But if there is a persistent hypoxia, the CNS will be directly stimulated with the resultant increase in the sympathetic activity. So you can have either a bradycardia, that is an acute response, but if there is a persistent hypoxia, the CNS will be directly stimulated with the resultant increase in sympathetic activity. So what happens is, when there is a hypoxia, there is a fall in the PaO2, acidosis, or an increase in the PaCO2, the receptors in the carotid body and the aortic body are stimulated. This is passed through the glossopharyngeal and the vagal nerve to the chemosensitive area in the medulla. There is an increased ventilatory drive and a parasympathetic activation. So this is how the chemoreceptor reflex acts. The anesthetic implication of this is that all anesthetic drugs cause except for ketamine, ether, and nitrous oxide, cause a dose-dependent reduction in ventilatory minute volume. So as alveolar ventilation decreases, there is a increase in the PaCO2. So normally, under normal circumstances, when this PaCO2 increases, there will be a rise in the increase in your ventilation, because this will be detected by the peripheral and the central chemoreceptors, and so there will be a rise in your ventilation. But what happens is that because of these anesthetic drugs, this response is blunted. So when these response is blunted, what happens is that they may not respond to a rise in PaCO2. This patient may not respond to a rise in PaCO2. So you have to be careful about that while anesthetizing patients. Don't think that just because a patient has the PaCO2 is increasing, their ventilatory drive will increase. You have to remember that their response to PaCO2 is blunted by the anesthetic agents. So that is the anesthetic importance of this particular reflex. Then comes the Bainbridge reflex, where you have stretch receptors in the right atrial wall and the cavo-atrial junction. So here the receptors are inside the heart, that is in the right atrial wall as well as in the cavo-atrial junction. So when there is an increase in the right-sided filling pressure, so when there is more fluid or blood going into the right heart, there are vagal afferent signals are sent again to the cardiovascular center in the medulla. And as a response, there is an inhibition of the parasympathetic activity. So here what you see is an inhibition of the parasympathetic activity. If you remember, when we talked about the baroreceptor reflex, it was the parasympathetic activity. So there was a decrease in a heart rate. Here there is an inhibition of the parasympathetic activity. So there is a rise in heart rate. And in addition, there is also a direct effect on the SA node by stretching the atrium. This again causes an acceleration of the heart rate. So increased right-sided filling pressure, the stretch receptors are stimulated. These are at the cavo-atrial and the right junction and the right atrial wall. The cardiovascular center in the medulla is stimulated, and this causes an inhibition of the parasympathetic activity, causing an increasing heart rate. Then the other thing about this is we all talk about is the reverse Bainbridge reflex, which is supposed to explain a decrease in the heart rate under conditions in which the venous return is reduced. Earlier, we were talking about a rise in the venous return. Here, if the venous return is reduced, there is an unloading or a deactivation of the atrial receptors, resulting in a reflex-induced bradycardia. So this is the reverse Bainbridge reflex. So here you can see, we talked about the Bainbridge reflex and we talked about the baroreceptor reflex. What we can see here is that with an intravenous infusion, you have increase in the right atrial pressure because your fluid is going into the right atrium. So the atrial receptors are stimulated, the Bainbridge reflex is stimulated, and so you have an increase in heart rate. Whereas when there is more fluid going into the heart, there is of course an increase in the cardiac output. So with this increase in cardiac output, you have an increase in blood pressure. And this stimulates the baroreceptor reflex. And so that will again cause a fall in the heart rate. So this is, these are both kind of complementary reflexes. So the Bainbridge reflex and the baroreceptor reflex act antagonistically to control the heart rate. The baroreceptor reflex acts to decrease the heart rate when the blood pressure rises. So what it said is that when the blood volume is increased, the Bainbridge reflex is dominant, and when the blood volume is decreased, the baroreceptor reflex is dominant. So I hope I haven't confused you by talking about both of this together. I hope it is clear. So now we will go on to the Basalt-Jarisch reflex. Here, what happens is when there are noxious ventricular stimuli given into the heart, that is due to various reasons. This is sensed by the chemoreceptors and the mechanoreceptors within the left ventricular wall. So here the receptors are in the left ventricular wall. So we've come from the carotids, the aorta to the atrium, and now we are talking about receptors in the left ventricular wall. So here there are chemoreceptors and mechanoreceptors in the left ventricular wall, and any noxious ventricular stimuli is sensed by these receptors, and this is transmitted by the unmyelinated vagal afferent type C fibers, and this reflexly increases the parasympathetic tone. So when parasympathetic tone is increased, what happens? You have a bradycardia. So you have a triad of hypotension, bradycardia, and coronary artery dilatation. So it produces an increase in the parasympathetic tone, and because it invokes bradycardia, it is thought of as a cardioprotective reflex. This is implicated in the physiological response to a range of cardiovascular conditions like myocardial ischemia or infarction, thrombolysis and revascularization, syncope. Natriuretic peptide receptors stimulated by endogenous ANP or BNP may modulate the Basalt-Jarisch reflex, and it may be less pronounced in patients who've got cardiac hypertrophy or atrial fibrillation. So next we come to the Valsalva maneuver, which is something which we all talk about. I'll just explain how this works. First, what we do is when we do a Valsalva maneuver, we ask them to close the nose and blow against it. This is something which we do intraoperatively also, where we squeeze the bag. So here there is a forced expiration against a closed glottis. So what happens when this forced expiration occurs? There is an increase in the intrathoracic pressure. So this increase in the intrathoracic pressure causes an increase in the central venous pressure, which results, because the central venous pressure is increased, the venous return reduces, and this reduces the cardiac output and the blood pressure. So the cardiac output and blood pressure will be decreased after the Valsalva maneuver, but this decrease will then be sensed by the baroreceptors and will reflexly result in an increase in heart rate and myocardial contractility through sympathetic stimulation. And in the next step, when the glottis opens, what happens is there is a venous return increase, because now that intrathoracic pressure is reduced, so the venous return increases. The heart responds with a vigorous contraction and increase in blood pressure. This increase in blood pressure is again sensed by the baroreceptors, and this stimulates the parasympathetic pathways. So fall in blood pressure is sensed, and that stimulates sympathetic pathways, and increase in blood pressure stimulates the parasympathetic pathways. So this is what happens with the Valsalva maneuver. Then the next reflex is the Cushing reflex, which is a reflex which is related to the intracranial pressure. When there is a raised intracranial pressure, there is a resultant cerebral ischemia. So what happens when there is a resultant cerebral ischemia is there a ischemia of the vasomotor center. So it's a total ischemia. So the vasomotor center again becomes ischemic, and so there is an initial inactivation of the sympathetic system because of the ischemia of the vasomotor center. So what happens is an increase in heart rate, BP, and a myocardial contractility. But secondary to that, there will be a high vascular tone, and this will result in a reflex bradycardia. So what you see with the Cushing's reflex is you have hypertension, bradycardia, and a diminished respiratory effort. The anesthetic implication of this is that antimuscarinic drugs like glycopyrrolate or atropine reduces the incidence of bradycardia, especially if the patient has got a history of a conduction block or vasovagal responses or beta blocker therapy. The other thing is that normally our chemoreceptor, the baroreceptor reflex is what regulates the blood pressure. But once it falls to a very low level, that is below 40 millimeters of mercury, there will not be much of regulation of the blood pressure. So to maintain the cerebral perfusion, this is kind of a last ray of hope for survival for the central nervous system ischemia response. So this is kind of a last ditch stand. This is a central nervous system ischemia response. So this is in a situation where the blood pressure has fallen to such a low level where the other reflexes do not work. So this is it's kind of a last ray of hope for survival by the brain, trying to improve the circulation. So the last reflex in our what we normally talk about the different cardiovascular reflex. The last one is the oculocardiac reflex, where when you have a pressure applied to the globe of the eye or traction on the surrounding structure. So here you have stretch receptors on the extraocular muscles. So when these receptors are stimulated, afferent signals pass through the short and the long ciliary nerves. So from there, they merge with the ophthalmic division of the trigeminal nerve. So from this long and short ciliary nerves, it goes to the ophthalmic division of the trigeminal nerve at the ciliary ganglion. And from there, the impulses are carried to the Gazarian ganglion. So there you have the extraocular muscles, long and short ciliary nerves, and from there to the ophthalmic division of the trigeminal nerve. From there, it is carried to the Gazarian ganglion. And what the response is, you have an increased parasympathetic tone and subsequent bradycardia. So that is why you have an increased incidence of bradycardia during ophthalmic surgery. Administration of glycopyrrolate or atropine reduces the incidence of bradycardia during ophthalmic surgeries. So I'll just go through a few more reflexes which we see in our anesthetic practice. One is the nasocardiac reflex. That is when you stimulate, because these are things that we see in our day-to-day practice, which is very common. So as postgraduates, I thought this, I will just add this also. When you, if you have a stimulus, like you putting a nasal pack or you intubate in a light plane, there is a stimulus, and this afferent is carried by the ethmoidal and maxillary division of the trigeminal, and the vagus is stimulated, and you have a resultant bradycardia and hypotension. The other is the rectocardiac reflex, where dilatation of the anal canal or instrumentation of the anal canal again stimulates the pelvic nerve, and the efferent is the vagus. So again, you have bradycardia and hypotension. Then the tracheal reflex, where again it's a vasovagal reflex, where if you stimulate the trachea, you irritate the trachea by secretion, suction, intubation, extubation at lighter planes. So this is something which we keep telling postgraduates. Once the patient is coming out of anesthesia, as the patient is coming into a light plane, if they start giving suction, we keep telling them don't do that, because this reflex is again going to be activated and they will respond with a bradycardia, arrhythmia, and hypotension. The other is a celiac plexus reflex, where stimulation of the stomach, gallbladder, or liver again can cause bradycardia, hypertension. and the diaphragmatic traction reflex, where manipulation or traction on the diaphragm can again cause a drop in blood pressure accompanied by bradycardia. So these are just the additional things which I just wanted to mention because these are things which we see in our common day-to-day practice. Thank you very much.
Thank you, madam, for the crisp presentation. Any comments or questions in the chat box? So there's one comment, Dr. Elizabeth.
Yeah, somebody has somebody has mentioned about laryngospasm. Yes, definitely. Because my topic is cardiovascular reflexes. I haven't gone into all those. I just mentioned these because these are practical applications of the reflexes. So that is why I didn't go into laryngospasm and the pathways for that. Yes, Mary's reflex is something which there is a reflex tachycardia. I'm sorry, I forgot to mention.
Okay. Any more comments or queries? Dr. Shamshad, madam is there? What reflex predominates in spinal? There's another question.
So actually, if we go to our old textbooks, we talk about the Bainbridge reflex, the reverse Bainbridge reflex, the Mary's law. So actually, if you look at the newer literature, they are all most of the new, because if you go to history, all these reflexes, this Bainbridge reflex and the reverse Bainbridge reflex, that was all postulated, quite several years ago. So when I was going through the literature now, what I saw is that we really cannot be very sure if it is actually this reverse Bainbridge reflex which causes the fall in decrease in heart rate, so theoretically we do say that it is a reverse Bainbridge reflex which causes the fall in the heart rate, but for your theory purposes you can say that, but whether it is actually true or not, I'm not very sure, because that's what the literature says now.
Okay, madam. Thank you. Thank you for the clarification. Any comments from the senior faculties? Gurudat sir is there. Dr. Shamshad Began is there.
Madam is there.
Gurudat sir is there. Shamshad madam is there.
Yeah. Elizabeth, you have done it very simple and very shortly. And it was such a difficult topic. It was very difficult to follow most of the people. I think so. Anyways, it was nicely presented. And that these are all the clinical applications was also apt to the questions, to the topic. Done it very nicely. Okay.
Thank you, ma'am.
I don't think anybody has got any questions now because you have done it very perfectly. That's the way that you have presented it.
Okay.
I hope it's not because everybody is confused.
They asked in the theory paper now. We are going to